ingrown toenail is also known as onychocryptosis, which is a word that can be broken down for onycho meaning nail, crypt meaning hidden, and osis meaning an abnormal condition. So thereby this is an abnormal condition where we have a hidden nail. It is also known as inguis incarnatus, and it is a common and painful form of nail disease. It is a condition that involves abnormal growth of a sharp piece of nail into the periungual skin. It is most common in teenagers and young adults during the second and third decades of life. The commonest symptom of which is pain in the affected nail, which if it is left untreated may lead to infection, discharge, and difficulty in walking, which will greatly hamper the quality of life of the individual. Ingrown toenails have a long history. During the colonial days, British foot soldiers were responsible for their own foot care. They were severely punished if they limped because of an ingrown nail. And in the Civil War Army manuals, soldiers were instructed to cut a V in the nail, hoping it might relieve ingrown nail pain. As expected, this didn't work. In more recent times, people have sought relief in hospital emergency rooms, manicure shops, or from podiatrists. Today, relief from painful or infected ingrown nails is not a difficult process. Local anesthesia to numb the affected toe can be done to allow for permanent remodeling of the side of the nail. These procedures are painless, brief, and very effective. Ingrown toenail, as earlier said, is the most common nail issue encountered in clinical settings. It is common in teenagers, young adults, and pregnant women compared to the rest of the population. The risk of occurrence increases with increase in age. The big toe, which is also known as the hallux, is the most commonly involved toe, with its lateral side more common than the medial side. The nail unit is located on the dorsal surface of the distal phalanx of the fingers and toes. It is made up of the nail itself is made up of hardened plates of keratin. The nails are one of the appendages that make up the integumentary system. Its functions are: one, for sensory assistance, which provides tactile input for the nerves in the underlying skin tissue, as a tool of functionality to do things like scratching, grasping of objects, and opening of objects. Or nails could also be ornamental, to act as a beauty accessory in many cultures. For example, we have henna, which is applied on the nails in women of northern Nigeria and sub-Saharan Africa. It can also be serve for protection, to protect and support the distal end of our digits as we engage in various tasks. The nail also has clinical relevance. It can be used for capillary refill tests, which less than 2 seconds is considered normal. And this is when we expect the underlying nail bed to blanch and refill. It can also be a pointer to underlying disease based on its shape or color. We see that in clubbing, the shape of the nail is altered, which is seen in chronic diseases, or koilonychia, which is spoon-shaped nails, which can be seen in iron deficiency anemia, or leukonychia, which is whitening of the nails, which is seen in liver diseases. The nail unit is made up of a nail body or nail plate, which is the outer portion of the nail unit. It is formed by layers of keratin, which forms a hard yet flexible and translucent plate. This is an illustration that shows us the nail plate here, which is superficial to this nail bed, and the lateral edges are the nail folds. So the nail folds is the skin that surrounds and protects the proximal and lateral margins of the nail plate. So this skin around the lateral edges and this proximal part is the nail fold. Then underneath the nail plate is a nail bed, which is otherwise known as the sterile matrix. It lies underneath the nail plate and attaches it to the distal phalanx, provides a smooth surface for the growing nail plate to slide over it. But it is important to note that it does not contribute to the plate growth itself. We have the germinal matrix, which is an area of soft tissue proximal to the sterile matrix. Cells within the germinal matrix divide and become keratinized to form the nail plate, and continuous cell division within this germinal matrix pushes the nail plate over the nail bed as it matures. So it's not visible in most individuals, but in some people the distal end can be seen as the lunula, which is this white thing we can see on the illustration here. This is the distal end of the germinal matrix. There we have the hyponychium, which is the area distal to the nail bed, situated under the free edge of the nail plate. And the eponychium, which is a layer of stratum corneum, which extends between the skin of the finger and proximal nail plate. This is the eponychium here, and the hyponychium, which is underneath the nail plate and distal to it. Underlying causes of ingrown toenail is a foreign body reaction between the keratin in the nail and the flesh of the toe. There have been various theories that have been proposed to explain the etiology of this ingrown toenail, but they can be broadly classified according to whether the primary fault is the nail itself or the soft tissue at the side of the nail. So if it's the nail itself, we'll consider the nail length. If the nail is cut too short, it will not be constrained by the distal portion of the cuticles, and it will allow side slippage and penetration of the lateral nail bed by the nail. If there's external pressure from wearing shoes that are too tight, they can compress the edges of the cuticles against the relatively stiff nail material, thereby turning the nail into a cutting surface. Other causes include excessive sweating, which can cause maceration of the skin of the nail folds, and this makes them soft and they can be easily penetrated by the nail in that condition. We have nail infections, for example, tinea inguinum or onychocryptosis nails. The nail plate becomes brittle. This can increase the risk of it breaking off and giving nail spicules that can go and penetrate the nail fold, the surrounding skin around it, to cause ingrown toenail. We have the nail apparatus abnormalities, which can be things like an improper shape of the nail plate if the nail folds are thick, or if there's a medial rotation of the big toe, or if there's reduced nail thickness. This can all play a role and lead to the development of ingrown toenail. Of which there's a very severe type, which is called the pincer nail, which is when the lateral edges of the nail plate are very close to each other. This increases the risk of ingrown toenail. We also have congenital onychocryptosis, which is an infrequent form of presentation that is believed to be due to an intrauterine trauma or hereditary transmission. So we manage ingrown toenail by history-taking, physical examination, investigation, and treatment. Under history, the patient will present with the cardinal signs of inflammation. The most common presenting complaint which is that of pain, of which the patient describes as a pain that is sharp in nature, that worsens with weight bearing or ambulation. It is also associated with difficulty ambulating or bearing weight on the affected foot. We could also have a foul-smelling discharge. History of foot care of the patient should be explored in the history, where maybe the patient wears tight shoes or they trim their nails poorly. You also want to know if the patient has had similar symptoms in the past and how it was managed, and if there's a family history of a similar condition. And history of chronic disease like diabetes, mellitus, hypertension, peripheral arterial disease, or sickle cell should be explored, as these diseases can impact wound healing. Physical examination, the patient could be in painful distress, could be febrile, or with or without dehydration on general examination. Then the affected toe could appear red, erythematous, could be swollen with or without differential warmth. Could also be granulation tissue or lateral nail wall hypertrophy visible around the periungual area. There are 3 stages of ingrown toenails. For stage 1, patient will have mild erythema, edema, and pain with pressure. Stage 2, patient has significant erythema, edema, local infection, and purulent discharge. And in stage 3, they will have all the stage 2 findings with granulation tissue formation and hypertrophy of the lateral nail wall. Besides, these are pictures to show what we see in ingrown toenail in stage 1 and stage 2. This looks more like stage 1, where we can see that the erythema and edema is less compared to this one, which has significant erythema and edema and a very shiny surface. Investigation. It's important to know that the diagnosis of ingrown toenail is clinical. However, studies have been done to rule out complications or prepare patients for surgery if needed. You may see leukocytosis with left hip, which indicates there's an ongoing infection, and anemia may be seen full blood count, which may show that patient's wound healing post-surgery may be affected. You can also do a foot X-ray, AP and oblique views to rule out osteomyelitis of the distal phalanx of the affected toe. Treatment could be conservative or surgical. For mild to moderate lesions with minimal to moderate pain, little erythema and no purulent drainage, this can be treated with conservative therapies. And for moderate to severe lesions with severe disabling pain, substantial erythema and purulent drainage, they may require surgical intervention. So for conservative methods of treatment, the first one could be an application of cotton bud under the nail to elevate it from the nail bed. And if this is painful, we have to soak the toe with warm water multiple times a day for 20 to 30 minutes. The aim of soaking it is to allow it to soften so that we can elevate the nail plate easily. However, if this soaking method fails, we can perform a digital block to elevate the nail plate. The second method, conservative method, is the gutter splint or sleeve technique. The gutter splint is prepared by slitting a small approximate cut, sterilized with vinyl IV drip infusion tube from top to bottom, and one of the ends is cut diagonally for smooth insertion. Then under local anesthesia, the lateral edge of the nail plate, including the spicule, is splinted with a lengthwise incised flexible plastic tube. The splint is pushed approximately till the nail spicule is totally covered by the split plastic tube. The plastic tube is then attached with either adhesive tape or wound closure strips. After splinting, the patient experiences instant relief of the pain, and they are instructed to wash the toe once daily with povidone iodine for up to 3 to 4 weeks. The splinter spicule grows out without injuring the nail fold, and the granulation tissue subsides. So this is an image of a stepwise procedure of when the gutter splint technique is done. You can see here that we have a mild ingrown toenail, and in this image, the nail margin is freed up, and in this one, you can see that the tube that has been cut is inserted and advanced proximally. And here we can see that the insertion is complete. So this would remain in place for 3 to 4 weeks, where the patient cleans it with iodine daily. The third method is the band-aid method, of which one end of the tape is placed against the side of the ingrown toenail along the granulation tissue, and the rest is twisted around the toe at an angle so that the other end overlaps the first but does not cover the wound itself. The principle is that this physically pulls the side of the nail bed away from the nail, and it can decrease the pressure while simultaneously improving drainage of accumulated pus and drying of the wound. So this is the band-aid method, where one end is applied and taken around, and this will now apply some form of traction so that the ingrown part will lift up and pus can easily drain from this part. We also have nail wiring. In this technique, 2 holes are made with 23 gauge needles at the distal free edge of the nail plate. An elastic wire is inserted until the degree of the nail plate becomes less than 60 degrees. The wire is bent forward, cut so that it does not protrude from the nail end, and the small hole made by the needle is filled with an adhesive agent. The elasticity of the wire helps in curing the deformity of the ingrown nail. So these are pictures to show the stepwise procedure. You see in the first picture here, there's an ingrown toenail. Then these 2 black dots are where the holes will be made using the 23 gauge needle. Then you insert the elastic wire there, and you straighten them, and you fix them with an adhesive to maintain a degree less than or greater than 60 degrees. So anesthesia for ingrown toenail is local anesthesia that is recommended, performed to provide a pain-free procedure for the patient using local anesthetic agents like lidocaine, procaine, or bupivacaine. It is important to avoid adrenaline due to the vascular complications that could occur. The metatarsal block is said to be safer compared to digital block due to the more expandable subcutaneous tissue and well-developed collateral circulation of the metatarsal area. This digital block now, you need a sterile field, you need your local anesthetic agent, and you need a small needle, preferably between 25 to 30 gauge needle. You also need wet swabs as well. So indications for this procedure could be ingrown toenail, if there's a phelon or a paronychia, if there's a fracture of the distal phalanx or maybe a dislocation that you want to manipulate, that's when you do this digital block. So it involves placing the plantar surface of the foot on a hard surface. We clean with iodine solution and clean the bottle of the anesthetic agent, even if it's a new one, so that you don't introduce infection into it. Then use a different needle to withdraw your local anesthetic agent into the syringe and change the needle to a smaller needle between a 25 gauge to 30 gauge needle. Then the aim is you want to block the plantar digital nerves and the dorsal digital nerves. So how we do it is that we inject at 90 degrees downwards, just distal to the metatarsophalangeal joint, which is here. And when the needle pierces the skin, you infiltrate and you notice some swelling around the area, and you advance deeper to infiltrate the palmar aspect on the lateral side. Then it's a 3-step technique where you just withdraw the needle and go medially and infiltrate the dorsal digital nerve on this side. Then bring the needle out and go up 90 degrees downward into this place so that you can infiltrate the palmar palmar digital nerve on the lateral surface. Other management options are surgical methods, which include the excision of the spicula, partial matricectomy, chemical partial matricectomy, wedge resection of the toenail and nail fold, and partial matricectomy, excision of the affected nail and total matricectomy. Others could be electrocautery, radiofrequency ablation, and carbon dioxide laser ablation. So excision of the spicula and partial matricectomy is carried out on individuals with mild ingrown toenail affecting the nail plate without hypertrophy of the nail fold. It can also be done in adult patients or elderly patients in whom tissue regeneration capacity is reduced and the likelihood of recurrence is lower. Consists of excision of the affected portion of the toenail and partial mechanical matricectomy with a scalpel. The second method is the chemical partial matricectomy using phenol. This is the gold standard treatment that is recommended for ingrown toenail. Advantages of using phenol is that it has a very high success rate of up to 90%. It is less painful, has a lower mobility than surgical excision of the matrix. It's likely that there's some phenolic nerve damage that could occur at the site of surgery, and this will provide some degree of analgesia but does not result in any long-term deficits. Indications for phenolic ablation include mild to moderate ingrown toenail, young or adolescent patients because they have great tissue regeneration capacity, and diabetic patients with controlled type 1 or 2 diabetes. The phenol alcohol technique is safe in diabetic patients who have good control of their diabetes. Although there's no reported side effects after phenol application for the treatment of ingrown nail, phenol application it can result in chemical burn and intense inflammatory changes. Though the recurrence rate is low at 5%, the post-op complications like delayed healing and discharge are more common. Other agents that we can use for chemical matricectomy include sodium hydroxide and trichloroacetic acid. This is the table comparing the different agents that we can use for chemical matricectomy. Resection of the toenail and nail fold is indicated for moderate to severe onychocryptosis and involves excision of the affected portion of the nail plates, partial matricectomy, and wedge removal of the hypertrophic nail fold and nail bed. Total matricectomy, this procedure is only indicated for severe ingrown toenail in adult patients which have onychodystrophy and onychogryposis and or chronic hypertrophy of the distal and lateral folds. Other techniques for matricectomy include carbon dioxide laser, radiofrequency, and electrocautery for matricectomy. CO2 carbon dioxide laser has been recommended as an effective primary modality of treatment with a success rate of 50 to 100%. Well-established advantages of the carbon dioxide laser technique are less bleeding, reduced post-op pain, immediate sterilization of the infected tissue, and limited thermal damage to the surrounding tissues. So for post-op care, we want patients on antibiotics because the antibiotic of choice should be efficacious against staphylococcal species, especially the Epidermidis species, as it is the most cultured pathogen. We also want to place our patients on analgesics for 3 to 5 days post-op. And we want to start with NSAIDs, except they are contraindicated in patients who have maybe peptic ulcer disease or who have chronic kidney disease. You want to be cautious with the use of NSAIDs there. And you want to do wound dressings for the patient, which can be removed 24 hours after surgery, and the patient can apply betadine ointment on the place, on the wound PD. We also want to advise the patients to avoid wearing shoes for 3 days and elevate the leg for 24 hours. For 24 to 48 hours, then you give them a follow-up clinic appointment in a week. Complications that could occur from untreated conditions include paronychia, cellulitis, osteomyelitis, and sepsis. Then from treatment, we could have early versus late, and we could also have complications from anesthesia. So for early complications, a patient can have pain, can be bleeding, a surgical site infection. Late complications, they could be reoccurrence, or it could be cosmetic. And from local anesthesia, there could be toe necrosis if adrenaline is used, or if we have could also have inadvertent intravascular injection of the anesthetic agent. There could also be allergic reaction to the anesthetic agent. By way of prevention, you want to counsel your patients to use properly fitted footwear, and you want it to have a wide toe box or an open toe. You want to counsel them about clipping their nails too short, and the nail edge should extend past the tissue of the lateral nail fold. And if they are clipping their nails, they should make a straight cross across the nail, not in an arc. And if there's any underlying pathogenic factors that are found in the patient, such as hyperhidrosis or onychomycosis, it should be treated or managed accordingly. In conclusion, ingrown toenail can occur for various reasons, including poorly fitted shoes, improper nail trimming, injury, previous infection, hereditary influence, nail fungus, deformed toes, and flat feet. Whatever the cause is, it can be managed with conservative or surgical means.
What is the chance of it reoccurring, and how can we prevent it from occurring in the first place?
Depending on the method of treatment, it can have a 10 to 30% reoccurrence rate. But if a radical or a total matrixectomy is performed, the chances of it reoccurring are 0. For prevention of ingrown toenails, we've seen the risk factors. We have to modify them. So if the patient wears tight shoes, we counsel them on foot care to avoid wearing tight shoes. And we want a shoe that has a wide toe box or an open shoe. Then also we counsel them on how they trim their nails. We don't want them to trim their nails in an arc. We want them to just do a horizontal trimming, and it shouldn't be cut too low as well. Then if there are other risk factors like hyperhidrosis, or if there's an ongoing nail infection, you'd want to manage those things actively.
I noticed that when you were talking about ingrowing toenails, you didn't really mention anything about the pathogenesis and how it occurs. You tried to explain it, but you didn't give a proper breakdown. And then you didn't mention how, you mentioned the sharp edge of the toenail penetrating the soft tissue layer, but you didn't explain that it forms like a foreign body, and then there's inflammation and granuloma formation, which is more like a foreign body inflammation that occurs. Then also, you didn't talk about classification of ingrowing toenails. We can have distal lateral ingrowing toenail, the lateral ingrowing toenail, and also the proximal, the retronychium. Then also, you didn't talk about differential diagnosis as well, the common differential diagnosis that you may have. A paronychia can be a differential diagnosis, as well as hepatic whitlow or some other conditions you can mention them. Then also some other things that I wanted to add in your risk factors. I think you mentioned congenital. I don't know if you mentioned congenital foot deformities that can predispose patients to having ingrowing toenails. And then my questions are: have you ever heard of drug-induced paronychium, and what is retronychium? Those are my 2 questions. Or retronychia, rather. So for retronychium, there's nail embedding the proximal fold. So rather than having a distal or a lateral ingrown toenail, it occurs proximally. And it's also as a result of minor trauma. Same risk factors also apply, but it is the proximal nail plate that is embedding into soft tissue and causing inflammation. That is retronychium. Then it has been known that there are some drugs that induce paronychium and paronychia, and then increases the risk factor for this development of ingrowing toenails. Most of them are monoclonal antibodies, like trastuzumab is one of them.
So I want to add that as part of your evaluation of the patient, you may need to do an X-ray of the foot. Sometimes it may be a foreign body that is there causing it. You get so you need to do an X-ray apart from the fact that you're doing PCT and all that. So if there's a radio-opaque foreign body, it may be picked and may be responsible for that. Sometimes all those things may present and may be confused for an ingrowing toenail. The other thing I wanted to mention is that certain times patients may present as with paronychia as a complication of the disease or concurrently occurring of the disease. So some persons may advise that you treat the infection first. That's because you know that there's already discharge because of the foreign body foreign body irritation occurring at the edge. But if there's also concurrent paronychia and pus around the fold, you should treat it before you now go ahead with your surgery. Then there are some named surgical procedures. If you've ever joined or you see us writing Zadik's procedure and all those. So I just wanted to contribute to that. I think what we do most of the time is called a window grade. You mentioned the procedures, but there was no eponymous name attached to it. So what we do most of the time is that first one you mentioned. I talked about spicle excision and partial matrixectomy. The reason why we remove the germinal matrix, as you've already mentioned, is that the germinal matrix is where the nail grows from. So once you remove it, then any new nail that is coming from that part will likely go straight. So what we do most of the time that we call Zadik's procedure is the Winograd procedure. What we do is that we remove we excise the affected nail, the nail bed there. We remove the matrix. We also remove the nail fold that is affected. We remove that most of the time all those granulation, they have excessive granulation tissue around there, and then we close. So what we do most of the time is a Winograd procedure. So what is that? A true Zadik's procedure involves removing the whole of the nail. That means we are removing the nail as with the sterile matrix, raising 3 flaps, removing it and suturing it back. There are other procedures, Fowler's procedures, that also can be done. So that one also is the whole of the nail is removed, and then with germinal matrix, and then we remove. So those are some things that we do. Prevention is also something very important, and good that you've already mentioned. Prevention is a condition that may recur. You already mentioned it, but if we do some of all these procedures, recurrence rate will be low.
The Zadik you described, how is it different from nail abortion?
So it's the same. Hello, sir. It's the same thing. The only thing is that in Zadik, they raised 3 flaps, so 2 angulated flaps are because in the nail abortion we don't need to make any incision over the eponychium or that's the proximal nail fold. So, but in Zadik we'll excise, we'll make 2 incisions so that we have now 3 flaps, 1 proximally and 2 lateral, so that we can really see the proximal nail fold. So that's it. For the nail abortion, we just remove the nail. We don't need to raise any flaps. And apart from that, when we do nail abortion, it's just for the nail. There's also, because in this we also have to address the lateral nail fold that is inflamed. So we have to take off that part. Sometimes the bone underlying proximal phalanx is also curated just to prevent any recurrence. So all those we don't do in the nail abortion.
You mentioned some of the risk factors to developing the ingrowing toenail. You know, it's a common risk factor, isn't it? Some abnormalities some structural abnormalities and some morphological abnormalities of the foot, like flat feet, hammer toes, claw feet, patients having calluses, bunions. Those are all named conditions that you see that predispose patients to onychocryptosis. Then I think in the literature, I'm sure you would have read that you hardly see ingrowing toenails in patients that, or should I say in individuals who are not yet mobile. Although yes, the congenital forms have been described. However, more commonly, you hardly see it in patients that are not mobile. That a patient is mobile, bearing weight, in addition to all those other risk factors or predisposing factors are, important in the etiology of ingrowing toenail. Then is there any other name you came across for ingrowing toenail while you were reading?
Inguis incarnatus.
So what does that mean, literally?
Embedded toenail.
Oh, what does the incarnatus mean? Now, whenever you see a name that you don't understand, it's important to check up the meaning. Sometimes you don't know where somebody might ask you, and maybe they're not expecting you to know. And if you do say it, then it will be a plus for you. So that incarnatus just means flesh colored. That typical appearance of the ingrowing toenail, how it appears over that lateral nail fold. The typical appearance where you see it looking flesh colored, like sort of like a granulation tissue sort of thing over that lateral nail fold. So inguis incarnatus, that's what it just means. Of course, the inguium just means the nail. Ingrowing toenail is actually a clinical diagnosis most times, isn't it? We hardly need to order for specific investigations. Like as you mentioned X-rays sometimes being required to rule out other differentials like osteomyelitis of the distal phalanx. But commonly, I'm sure you'd have seen in the clinics that it's a clinical diagnosis. What stage do we commonly see it here, especially in our clinics, So commonly, the ones I've seen, they usually come in the second stage. Usually you see them with that, all those signs of inflammation, the redness, the swelling, the pain, and then commonly they're infected. Commonly they present with infection. And so you need to treat that infection before you even proceed to operative management. Then did you come across another treatment modality for ingrowing toenail known as Onychocryptosis? It is a modality that is more used in probably the early stages of onychocryptosis. It involves using a sort of like a resin substance, a resin material, sort of like an adhesive to apply over just distal to the cuticle. Once that is applied, it sort of like prevents that abnormal growth of the nail plate into the skin. It can be applied more proximally, and then over time, if that doesn't work, it can be applied even more proximally. Then it's also important to note that the surgical management of onychocryptosis is usually a clinic procedure. Commonly here in our environment, we do it, we do it in the theater, but it could be done as a clinic procedure because, as you mentioned before, most of the cases are done using digital blocks or metatarsal blocks. So I think that is worthy of mention as well. And then still, in addition to some of the risk factors, the fact that patients that walk in an abnormal fashion, some people you might see them walking more to their right or to their left side. So the fact that they're applying more pressure on that aspect of the foot, and of course which translates to the toes, bearing in mind that the hallux, the big toe, is the one that is most commonly affected. We usually commonly have, that is a risk factor, should I say, it predisposes those patients to developing onychocryptosis.
You commonly do the surgical procedures. What we do is that we do a wedge excision of the affected nail, as well as the matrix and the nail bed there, and then the affected lateral nail fold. Then we close. We just try to still scrape off the underlying the phalanx there, and then we close.
What we do is mechanical matrixectomy, or we excise that matrix out, as opposed to dropping your phenol in that position, in that spot to do the matrixectomy. This can also be a dissertation topic for who is interested. We can start doing chemical matrixectomy. We can compare it with the mechanical one. TCA is readily available. Trichloroacetic acid is readily available. We use it a lot for chemical peels on the face. We can compare the mechanical one we do, the winograd, and compare it with TCA matrix, chemical matrixectomy for ingrowing toenails, and compare the outcome. I think it will also be a good topic. Those are a little different. The problem is getting patients. I don't know There are times they are a little common. It's not likely in a year we'll not be able to get up to 10. I don't think so. Is there a place for use of tourniquet in surgery, surgical ingrowing toenail surgery?
Tourniquets can be used for ingrowing toenail procedures, surgical procedures.
Because the tourniquet that is applied at the base of the digit will help us achieve a bloodless field. That bloodless field would ensure that the bloodless field will help us ensure that the sterile matrix is removed, and even the germinal matrix is removed, and the scraping of any other residual that is beneath there would be easily visualized if there's a bloodless field. We're supposed to also scrape the base of the surface of the metatarsal, the phalanx, just underneath the germinal matrix. So to help us do that accurately, if there's blood, it may obscure vision and the surgery may not be done correctly.
And I'm always saying you will scrape the surface of the phalanx. That's
Yes,
a
sir.
dangerous technique. You excise the germinal matrix, the affected side. If you have done enough of this surgery before, you will know tourniquet is almost inevitable. If you are familiar with surgery for ingrowing toenail, whether you are seeing stage 1 or you are seeing stage 2 or you are seeing stage 3, in all of them, is there anyone you don't find a erythema?
It's from stage 1.
Erythema and swelling. So, if you are familiar with the surgery, you know that once you put scalpel to that area, there's a lot of bleeding, profuse bleeding. If you don't have any way of controlling blood loss, you might not be able to see that germinal matrix and excise it properly. And that will be one of the reasons why there is recurrence. If you don't take out that germinal matrix completely, you may likely have recurrence. So ability to have a bloodless feed and do a proper matrix excision. Since we are not doing phenols or chemicals here, tourniquet is almost inevitable. Some people have described use of lidocaine with adrenaline just to reduce blood loss for that surgery. And as we've said, studies have not shown that using lidocaine with adrenaline is contraindicated for digits in selected patients. There are patients where it may be absolutely contraindicated, patients that have vascular diseases, Wagner's disease, and the rest. But for the regular patient, use of lidocaine and adrenaline in the block is not absolutely contraindicated. So because of that blood loss, some people may want to use lidocaine adrenaline. But because of fear of safety, why use it when you can easily put a tourniquet and get the same result? So tourniquets are almost inevitable. A small tourniquet at the base of the toe is almost inevitable for proper ingrowing toenail surgery. The study showed that mechanical excision of the matrixectomy has less recurrence rate than chemical matrixectomy. So those standard things, I think we should be a little careful when we say it, because there's a Cochrane study that shows that if you do it surgically, if you excise the matrix surgically, the recurrence rate is less than when you do chemical matrixectomy.
For management of retronychia, we do a total matrixectomy, balls the nail and then do a total matrixectomy.